Hi, everyone. It's Dr. Sadaf, and I'm so excited to let you know about a free webinar I am hosting on August 25th at 7 p.m. Eastern Time. It is going to be on menopause for men. Yes, you heard that right. Menopause for men. How a man or a partner can support their partner during midlife. So really important information. I get a lot of questions asked to me by people coming in and saying that, they're learning about menopause, but their husbands don't know and they don't know how to support them. And they just feel like they're being, angry and irritable on purpose, which of course, maybe that's part of the thing, but not really. But they would like some information that their husbands could learn from. And so I am doing this webinar just for your partners. And of course, you're welcome to join in and listen in if you find it to be valuable. It's going to be valuable. It's going to have a lot of good information. But the key thing that I'm going to focus on is how your partner can support you in midlife. So remember, it's going to be August 25th, 7 p.m. Eastern. I'll have the link in the show notes for you to register, but also it'll be on my social media. My social media handle is at Dr. Sadaf OBGYN on both Instagram and TikTok. And on YouTube, it's the Muslim Sex Podcast and Fembe Health. So make sure you look out for all of those registrations and make sure you register for August 25th, 7 p.m. Menopause for Men. And see you there. I'm an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf Lodi, and this episode is everything you need to know about your metabolic health. And specifically, if you're South Asian, you should definitely listen up because we are going to be talking about the cardiometabolic risk factors in South Asians and how that impacts your life and also how that impacts your sexuality and also menopause. So it's going to be really good stuff today. As always, this is not meant to be any type of medical advice. So if you have any questions about your health, definitely speak with a healthcare provider. And if you have any questions about your religion, make sure you speak with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So today I am super excited to welcome to the show Dr. Chhaya Makhija. And Dr. Makhija, if you could introduce yourself to the audience, please.
Yes. Thank you, Dr. Sadaf. Thank you for having me on the podcast. Hi, everyone. I'm Dr. Chhaya Makhija. I am a triple board certified endocrinologist and lifestyle medicine specialist, originally from India, and in and out, absolutely Indian. In terms of, I don't know if this podcast is published on YouTube or not, so I wanted to share that with the audience.
It is on YouTube.
Thank you. Born and raised there, and medical school was in India as well. And I am originally a Sindhi, so I have a lot of connections with Pakistan. My grandparents, parents, everyone were born in northern area of Pakistan. So the dialect is kind of similar in terms of scripting. I reside in California, and I've been here for last 20 plus years, practicing and enjoying the integration of lifestyle medicine and endocrinology in this setting. I'm also the CEO founder of my practice. It's called Unified Endocrine and Diabetes Care, and expanding globally now, providing consultations to our people. So I really wanted to focus on South Asian women and men in terms of their prevention. And that is, I think that's your passion too, Dr. Lodi. So I would love to share a lot of clinical experience in this realm. In terms of other stuff that I actually engage with our patients is a lot of breath work. I have events or classes that I conduct with my patients and community. You call it as laughter yoga. It's just basically laughter and having fun with them. And also, how to tackle the perception of stress. So I don't call it as stress management in my office or in my care, but how we can respond to it and still live the best of life that we could. And ready for all your questions, Dr. Lodi.
All right, sounds great. Dr. Makija, we are, as I've been thinking about this podcast with you, I was really excited because one, you're an endocrinologist, so you deal all with hormones and diabetes and metabolic syndrome that can happen to us as we get older.
Mhm.
And for those people that may not know, like, what the heck is metabolic syndrome? So maybe you can just explain what that is.
Sure, yeah. So let's simplify it. When we talk about endocrinology, it's yes, study of hormones, but it's endocrine, diabetes, endocrine, and metabolism. Metabolism is basically your machinery. So your engine, your body, and your cells. We have trillions of them, and each cell in our body is an engine because it takes some fuel. One of the fuel is glucose, and then it has a lot of pathways or steps. Based on that, it produces energy. Or it may start producing certain hormones or chemicals or compounds that are helping to run the engine where it is supposed to be at and how it is supposed to be running. And it's also gender based, it's also age based, and of course, and there are several other factors affecting it. So that's metabolism. And in terms of why we talk about metabolic syndrome, or a syndrome is a conglomerate of certain conditions that are defined by scientific societies or by the American medical societies and even worldwide well recognized, is a lot to do with our waist circumference. It's a lot to do with risk factors that are causing heart disease. So, example like hypertension, that's high blood pressure, dyslipidemia or hyperlipidemia or hypertriglyceridemia. So, these are different types of cholesterol components that we can break down in the latter half of our conversation. And then comes either glucose tolerance. You are probably familiar with prediabetes or type 2 diabetes. So the physical aspects, waist circumference, we're getting away from just including body mass index as a part of this metabolic dysfunction or metabolic syndrome, but also your cholesterol, your blood pressure parameters, your muscle mass is what we're starting to look at. And of course, the glucose component, which is glucose intolerance, prediabetes, type 2 diabetes, insulin resistance. Um, so that's affecting our metabolism. That is how our machinery is running. And if it's impaired, it's not functioning appropriately, it's dysfunctional, and that leads to metabolic syndrome. And I won't miss out on an important component, which is, non-alcoholic fatty liver disease. And now that is also has a different term, which is metabolic dysfunction. Which is relevant to the liver. So all these are very much relevant to our South Asian population because we rock in terms of the incidence and prevalence in metabolic syndrome. We actually rock in numbers, which is sad, but it's a fact. And I feel like, physicians like you, me, and there are so many of them, which are now bringing about the awareness and helping and serving our people both within this country and also internationally.
Yeah, absolutely. Absolutely. So this is something that is super duper important. And I'd love to get into a little bit more of it. So, I did a whole podcast on the Masala study and I talked about its effects. So Masala stands for the mediators of atherosclerosis in South Asians living in America. And this study is a multi-center study, so it's taking patients over from UCSF, Northwestern, and now they included NYU. And so I'm curious, and maybe I know you and I talked a little bit about this offline, but what makes this study so groundbreaking? You think for South Asians and South Asian women?
Mm-hmm. Yes, well, groundbreaking one, very important, is it's the first of its kind. So, we've had, you were also mentioning, so South Asians would be, correct me if I miss anything. So, Bangladesh, Nepal, India, Pakistan, Sri Lanka, Am I missing any other countries? So that's entire
Subset.
subset of South Asians. But this group of population has not been studied, despite we, like I said, rocking, or we have the highest prevalence and incidence of metabolic syndrome, type 2 diabetes, and cardiovascular diseases. And whatever studies we have, a lot of them published in our ACC journals at American College of Cardiology, is all relevant to the other ethnicities in the world. And of course, with Europe, Australia, New Zealand, and United States of America uh, having more research in terms of their foundations for medicine, there is a lack of this ethnic population being included in the study. So that's why the Masala study is one of its first ones to just focus on this specific South Asian population, to look at what is necessarily different in this specific ethnicity versus the others, and what are the triggering factors, predisposing factors, or anything different that is contributing to this higher risk of cardiovascular disease. This one, that was one of the reasons for groundbreaking. The other thing is we learned a lot, that whatever we know, and especially in medical school, in our training, we learn about a list of predisposing factors or risk factors. You eat this, and this will lead to glucose or diabetes. You do not work out, or if you're at this particular weight, you have a higher risk of cardiovascular disease or type 2 diabetes. But this went beyond the traditional cutoffs that we have, even for weight and BMI. The other interesting part was they actually had almost, to my recollection, 50-50% of men and women, in terms of including that, both the genders. So that's very important, and so that we could have a subset of analysis for now women in this specific study. The other thing was, I think it went from mid adult group, so between age, I think mid 40s, or 40, to almost 80s. So that's a large group of population that they included, and actually where the highest risk of these conditions occur.
Hmm. Yeah, so we talk a little bit about, in that Masala study, they talked about heart disease, diabetes, and metabolic conditions. Does it show up differently in South Asians, do you think? Especially women. I know that, like, cardiac disease, right? We know that women don't often have that, that severe chest pain. They may have the pain radiating down the left arm. What do you see in terms of, like, your patients that you've seen, as an endocrinologist? How does heart disease show up perhaps differently for women than it does for men? Men, sometimes, a lot of times, will have like a heart attack, right? Or that may be the first time that they realize that they have this heart disease. Maybe they'll have erectile dysfunction, right? We know that one of the smaller arteries that supplies the penis, right? If that's the first thing to go. So if those smaller arteries are blocked, then we can think that, perhaps some of the arteries in the heart are also blocked. So what do you see in for women?
Yeah. So, as much as we know, and how the data was looked at in this specific study, the Masala study, so I'll just focus on women, right? So when we look at women, it's not just age that we are looking at, right? We are also looking at the phases of our life, which is directly related to our estrogen and progesterone, specifically estrogen. So, and I'll also share my clinical experience. So, one thing about South Asian women in general, like if you look at the population, they are leaner, shorter as compared to, say, European, or even individuals residing, or the ethnicities here in the United States of America. So those are physically, when you look at the phenotype, it appears as healthy, and I'm not talking about the other parameters, right? So one thing was screening. So the screening is not done because you think that, if you do not fit this specific weight category or BMI category, you're healthy. So the delays in terms of screening or recognizing a problem. So we talked about, the estrogen changes that we can get into details that happen in women, increasing the risk of cardiovascular heart disease. I always talk about, with specifically with masala study, that it showed direct correlation with increasing the blood pressure. So as our estrogen is declining, there are a lot of metabolic changes happening. One of them is high blood pressure, and it's usually the systolic, which is the top number, and that's related directly to your sympathetic nervous system. That's directly also contributing to more episodes of palpitations, arrhythmias, tachycardia in that perimenopause, menopause age. The second thing was just a false perception of weight and being healthy based on that weight. The third thing is, how our metabolism changes with the fat deposition. So, appearance of the visceral fat, which is only seen when you get specific testing done. If it's not done, you think that you're good. You do not need to worry about your health because your weight is okay. The third aspect was, just the increasing incidence, right? So when you talked about symptoms in men where they have chest pain or the peripheral vascular disease or erectile dysfunction, in females, there is a trend towards that symptom, which is more relevant to arrhythmias, even though their calcium score may be zero. Right, so that one thing is just the sympathetic nervous system activation, which is happening. The second thing is the lipid profile changes that are happening. The third thing is visceral fat changes that are happening. Now, visceral fat is as simple as bad fat getting surrounded by your organs, and it's more resistant meaning it just loves to hold on, and difficult to just shed, but that's leading to inflammation. So that's where I'm coming to the fourth aspect is the inflammatory markers in our blood vessels, which again may not cause symptoms, but they are building on to the inflammation, leading to that atherosclerosis later on rather than just during that perimenopause, menopausal age group. In terms of symptoms, a lot is relevant to or it's masked by menopausal symptoms. So there are a couple of studies which are more meta-analysis or retrospective based on hot flashes. So the more women experiencing hot flashes tend to have a higher incidence or risk profile is worse for the cardiovascular risk disease. So when you have hot flashes, it is related to our blood vessels. There is vasodilatation happening, and somehow it has been shown that there is a correlation that those individuals, those women, tend to have a higher risk of cardiovascular heart disease. And then the others that I talked about was dyslipidemia, hypertension, which are not symptoms. These are signs. These are blood test or clinical evaluation. Palpitation is a symptom, but that is just a risk of showing that you're pretty, estrogen deficient. Yes, you can get all the cardiac workup. It may be negative. Your CT calcium score may be negative, but that's also a symptom which tells you that there are cardiac changes occurring. May not be directly atherosclerosis, but the process has started. The last piece is pre-diabetes, insulin resistance, and type 2 diabetes. Does it have symptoms? Not really when it's just borderline or when you've just started getting diagnosed. But in women, there is this fatigue which is still prevalent despite being on a very good dose of hormone replacement therapy, despite being very active, and that's correlated with inflammation, the vascular inflammation that we talked about. The other is, just how the resistant the weight gets, and that's the central deposition of the weight. The third thing is sleep. right? So the sleep disruption is also one of the risk factors that leads to the cardiovascular or worsening of the cardiovascular risk profile. Again, it's not a symptom, but the disruption of sleep, if not corrected, increases their chances of having near future cardiovascular disease. Because they already have the estrogen deficiency, they're also shifting metabolically, and now we are worsening their technically their complications, that is having cardiovascular risk, uh, three of them, but we are not addressing it by those preventive measures. So symptom wise, long answer was what I described, but a short answer is the fatigue, the hot flashes, palpitations, and then the weight distribution in the central area for women.
Yeah, so are you saying that if women have heart palpitations in perimenopause, that could be a sign of cardiac disease?
Not cardiac disease, but cardiac arrhythmias, right?
Hmm.
And their calcium score, CT calcium score, will probably be negative. Most of the times it's negative. Their cardiac workup is negative, right? But it's affecting their arrhythmia, their electrical activity per se, right? And it's a sign, right? It's a sign that my estrogen is declining. So now I'm specifically focusing on Southeast Asian women, right? And those women that I see as we follow them. And you'll see that in, again, like, see, these are all data, which is, like I said, retrospective or meta analysis, that if they're not treated, they bound to have a higher prevalence of cardiovascular conditions as well.
Hmm.
Knowing that they are more sensitive to the estrogen deficiency, and they're in the process of this metabolic dysfunction. So it's not visual, the tests are negative at that time. Masala study is a great one to again re-emphasize, where they did not notice any. I think initially in your conversation you said that did not show any carotid intima thickness. Their
Mhm.
CT calcium scores were negative, but they were still at a higher risk for cardiovascular disease. Right?
Yeah, you and I were talking a little bit offline about how, South Asians make a quarter of the world's population, but carry 60% of the cardiac burden. And, I think that this has a lot to do with our genetics, right? And how could a whole ethnicity have an increased risk, right? I mean, I've never heard of such a thing where a whole ethnicity has this
Yeah.
increased cardiac risk, right? And some of the theories of that is that of colonialism, right? And the forced starvation of Southeast Asians by the British that had
Mhm.
colonized Southeast Asia. And because of that famine and starvation, we had this buildup of increase of visceral fat to right for survival mode. And at that time it worked, but now it doesn't. And actually,
Mhm.
when we have increased visceral fat, it definitely increases the risk of diabetes and decreased insulin sensitivity, right? So
Yeah, yeah.
that's
The
why.
other aspect, I've read a few studies, and this was when I was presenting it to cardiologists, because we were seeing some young men having, in very good condition, again, residing in the United States of America, getting this hospitalization and stenting because of a sudden MI, acute MI. And what we've looked at, and there's a lot of literature, especially in pathology journals, that our carotid arteries are narrower compared
Interesting.
to the other ethnicities. So just in general, the diameter is narrower for coronary vessels, to be very specific, as compared to the other ethnic population. And of course, the second thing is pretty well known, that we have less muscle in our legs
Yeah.
and arms. So our extremities, they just don't have enough muscles. Just how we, yes, you're right about the genes and the inheritance structure over centuries, but we just have less muscle mass in general, especially the extremities, as compared to the other ethnicities, Europeans, and again, Caucasians, and in Australia and New Zealand. So when you compare that, we just don't have enough lean body mass as compared to the other ethnic population.
Yeah, and we know that muscle is the key to longevity. So that's why it's even, more important for us to build that because we start out with less of that lean muscle mass. So, you know, um, going back, I think a little bit to kind of midlife and menopause and, how South Asian women see it, how do you think menopause is viewed in the South Asian community?
Oh my gosh, it's I can tell you stories and stories. So I visit India twice a year as my goal, and with menopause, one is like, oh, it's your age, and this is just going to happen. But I'll also say that even menstrual cycles, when we are advanced and we have so much education, and even the South Asia is advancing in technology, advancing in science, and they're exposed to the internet very rapidly in the last decade. But women's health, and I would just go back a little, even females having menstrual cycles are still considered impure, or there's considered to be
Like stigma
perfect
and
enough.
taboo?
Yeah, stigma and taboo, but not perfect enough to join a conversation, to join an occasion, or to attend some ceremony because they are, in having their menstrual cycles, and that's not an acceptable phase, or it's not supposed to be deemed, auspicious. As simple as that.
So
Now,
that is, I would, put a
yeah.
caveat to that. So like because different religions view it differently. So
Mhm.
is that more with, the uh, religion that you ascribe to? Because that's not the way that it is in Islam. I mean, women are not, they participate in, very important things,
Right. So,
even when they're
menopause is
menstruating.
being very specific to India, right? Like I said, it's very advanced, but in lots of pockets. So, when we talk about the population just in India, it's almost crossing to be the topmost, competing with China. And then, like you said, with all the South Asians, we are the max in terms of just that group, like one fourth, right? And This is the stigma. The description that I gave is a lot to do with India, and India has so many religions, literally every state, and then within that state we have a lot of uh, sub groups which could be believing in different faiths. So I'm not talking about religion or faith here, but in general, whatever the custom is, there is a lot of bias still going on, even in that phase of a woman's life. So now coming to the perimenopause, menopause era for the women, there is forget about lack of knowledge. It hasn't been adapted by the healthcare system as much. So I know in our country, in the United States today, there is so much advocacy going on, and we are still fighting with FDA. And I see women leaders going through that process to bring about just a simple prescription of vaginal estrogen and to bring about the safety of HRT. In the South Asia population, right? They don't even have the time or the right awareness that if I am suffering through a symptom, and this is again being talking about women, there is no recognition that if I'm going through a symptom, which is a whole list of menopausal symptoms, that I can get care. It's assumed that this is how it is supposed to be because I'm aging, or this is how I'm supposed to suffer or not speak up. On the other hand, when I talk to my colleagues, who are gynecologists, well established, that why is there no HRT, or I see my aunties complaining of recurrent urinary tract infections, vaginal itching, and seeking antibiotics literally every few months. Why is there no vaginal estrogen? The response I get from gynecologists, I'm talking about larger cities, that even if I give a prescription for vaginal estrogen, they're not going to use it because they think that they're harming their body by using hormone therapy. The second is vaginal estrogen is barely available. I personally looked through it 6 months ago, and I had to go through at least 13 pharmacies to figure out if they carry vaginal estrogen. And by the way, in most of these countries, you don't need a prescription to get you don't need a doctor's prescription to get the medication. right? So access, the education, the awareness or knowledge, even for women. So forget about educating men right now or the families. Even the women are so anti, and I'm talking about the entire population. I'm not focusing on just one subset. But after talking to both the physicians and specifically gynecologists, families, friends, people who are actually suffering, it's like, no, I would prefer a lubricant to prevent UTI. It's okay. I'll just hydrate myself. I'll end up getting these herbs, which will help me. Um, I'll go for Ayurveda, I'll go for homeopathy, which are all fine in their own realm of the world when they're safe, right? But the point is that menopause is a part of your age. You can't do anything. This is how it's going to be. You are going to gain weight, you are going to get weak, your bones are going to break, and you're going to get the hot flashes. Your libido, if that sucks, it sucks. Who cares? Let your spouse figure out another solution. But this has just become a norm. When I was in Bombay, it was getting more advanced, like women stepping up and trying to seek care. But it's a very small subset of the entire population.
Yeah, that's interesting that you mention all of that.
Yeah,
So I don't know. I'm not from India, so I don't know. The culture over there, but
yeah.
I would say it's probably similar to Pakistan in a lot of respects. And when I went to go visit my cousin about last February, I went there for 2 weeks, and my cousin is actually a gynecologist as well. And I asked her about hormones and menopause and all of this
Mm,
stuff, and she said, we don't have hormones here. She
mm,
said, I said, so what do you do for the women? She said, we do nothing. Um,
mm,
and I was talking to, another one of my cousins who's very, is in her 40s and has gone through menopause, late 40s. And, I told her that, I had some estrogen with me, but I told her, I don't want you to take it unless you can get some progesterone. And she looked everywhere and there was nowhere for her to find progesterone. So she actually ended up giving that medication back to me and said, I can't use this because I
mm.
can't find the progesterone. So, I think that definitely there is, a lack of understanding of what's going on in our bodies during our different reproductive stages of our lives. And I think also that there is not that priority that I see. And this is, remember, even here in the US, right? Women were not included in scientific studies up until
Yeah,
1993. So it's not like, our countries are so far behind. But
yeah,
still, I think that women's health, honestly, is probably not prioritized, right, in our countries. It's unfortunate, but it's true. And I think to your point, what you said about, just seeing menopause as just a function of aging, and that's just the way things are going to be. I think, and this is a conversation, actually, this is a theme that I've recorded a few podcasts today, and this is a theme in actually all of our podcasts that I've recorded today, is that women are used to suffering. And they suffer when they have these menstrual cramps and bleed. They suffer if they have endometriosis, if they have fibroids. They're suffering in labor. They're suffering when they get into menopause, and it's just become so normalized, right? Like, you just suffer. There's nothing to do about it. This just happens. You're just gonna. And I think that's really unfortunate. I think the way that we change that narrative is through education and letting women know that no, you don't have to suffer, that there are options, that there are medications, and you have to find the right people so that you can get those, that treatment that you need. And, we're very lucky here in the US that we have the education, but we also have the medication, right? You can't find these medications. And like you just said, you went to 13 different pharmacies, try to see if you can find this vaginal estrogen. You had a hard time finding it. When I asked my cousin who's a gynecologist, she said they don't even have it, right? So, I think that if I were to be able to give one medication throughout the world, right, to women, it would be vaginal estrogen. And my tagline would be saving marriages and saving lives, right? That's really what it does. And also, I mean, we don't even mention the health that it, brings back to the vulva, right? Replacing, creating a normal vaginal microbiome, reducing overactive bladder, reducing recurrent UTIs, increasing lubrication, decreasing pain with sex. I mean, there's so many things that the vaginal estrogen does. And, if we could bring that over to our countries, I think that it would just change the whole landscape there.
I agree. I agree. Yeah. And it's, we feel that empowerment is just, say, internal or physical, but, not having that suffering is so empowering. Not
Yeah.
having that piece of suffering. Yes. Yeah.
Yeah. Do you think that there's a way that women can balance religious or cultural values with their own needs around, like, say, intimacy, pleasure, and partnership? I don't know what, like, it's definitely not something that's talked about in most Southeast Asian cultures about pleasure and intimacy. Um, do you find that it's hard? Like, do your patients come to you? Do they ever talk about that? Or do you think they just probably talk about it with their gynecologist?
hmm Most of the time, so in my previous practice, because it was endocrinology where I was employed, we barely had, we didn't, I was not allowed to see patients with these symptoms. It was just thyroid cancer, osteoporosis, diabetes, the general endocrinology. But now, in the last 4 years at my practice, I just have them self-refer. Like patients decide, right, if they need to see me, and we do have those discussions. So I'm in Central California. So we have, North Indians here who've been residing here for almost 2, 3 generations, and then of course the Bay Area, which is more of a diverse population for South Asians in that neighborhood. Most of them, like I would say, the ones who are professionals, very highly qualified, they actually prefer talking as a couple, versus the others are more individual consultations. And again, these consultations are not necessary for the symptoms that you just told me, but it's overall when we're talking about other pieces of their health in the realm of endocrinology, and then talking about libido or the intimacy and the sex aspect of with their partner, right? So when you asked me, was, is it faith, religion, keeping that intact and having that balance, correct, of those discussions. um, if they're living in a joint family, and if the partner, and I'm focusing on women, and if their partner has no idea of women's
Anatomy?
not anatomy, but actually the physiology aspect of it, like how things shift, the menstrual cycle, postpartum, ovulation versus the mood changes, perimenopause or premenstrual symptoms. It's very hard for that individual woman to talk about it. I'm getting out of South Asians now. Even my Caucasian female patients, and especially in the postpartum period, they come to me that, Dr. Makhija, I'm fine, getting better. I'm still nursing, but I have no libido. Do you think I can take testosterone? Right, and they've already taken testosterone injections from different med spas, wellness centers, because the spouse doesn't get the understanding that what happens in the postpartum period, right? So there is, and even though many of them are physicians, very well qualified, they just don't have an understanding of what's going on in their physiology postpartum period, which is very similar in terms of the estrogen fluctuations in perimenopause and menopause. And that discussion goes beyond a religion or faith. It's just between the person and the partner. And
Yeah.
it's a lot to do with, can we initiate a conversation of what my body is going through, not necessarily just what I'm going through, but what my body is going through, and then how that's impacting my emotions, right? And then what can we work on, right? And then you just start seeking, okay, do I need pharmacological therapy, or is it more counseling? Is it more wait and watch before the woman recovers? So those are the discussions that we tend to have in the office when it is during this specific phase. Perimenopause and menopause, I think we have more answers now in last 3 years, last 3, 4 years, with more availability of, or more availability of resources. Women physicians stepping up, guidelines stepping up. So it's a simpler conversation for me, I would say, in the last 3 years with women and men, when the changes are happening in that perimenopause, menopause, for intimacy, for sex, for the education for both the partner and the actual individual, the woman who's going through it. But until and unless the partner doesn't get it, it's very difficult for that person, the patient, to handle everything by themselves.
Yeah, I
So,
mean, I would say that postpartum actually, with breastfeeding, actually what happens is that you have an increase in prolactin, right? So prolactin allows that milk to come down, and so there's a suppression of that estrogen and progesterone, and that's why but sometimes people, right, if they're not breastfeeding all the time, they can still ovulate, and that's why they think that they don't
yeah,
ovulate. That's how women end up getting pregnant. But I would say that, when women are breastfeeding, actually, it's similar to them actually even being menopausal, right? Because those
correct.
hormones are low. And so that's why, they suggest using vaginal estrogen during that time as well. But, I would say that, when women come in with a decreased libido, right, I think there is a cultural component of how one that they're informed, two that they understand that it's not just a matter of medication, but that it's a whole biopsychosocial aspect, right? It's like looking at, what is their psychological state? What are the social factors? Like you said, if they're in a joint home, right, joint family, they may not be able to be as intimate or, have sex as often as they want to. Maybe their, parents are in the door, in the bedroom next door, right, sleeping next door. So I think that there's definitely a lot of factors, and sometimes it can be hard to have those conversations. And especially if they grow up in sex negative, or sex negativity. I know that there's a lot of women that have grown up like that. And so they, may already have these ideas in their head that sex is wrong, shameful, taboo, and that they may not be able to have those conversations. What do you think every woman should know about their hormones over the age of 35?
You got to conquer it. So, the more we know, I think there are two ways that I see happening. One is the fear and anxiety. So I was just talking to one of the nurses, and she's 35, and she's like, Dr. Makija, how do you feel like you're doing so many things? And I just told her that, oh my gosh, I'm getting a night sweat. I'm already 45. I feel like I need my HRT coming on soon. So she's like, oh, I'm dreading that age. So one place is that so much at age 35 that you add fear and anxiety that what will happen to me when I go through the shift, right? Versus you have the knowledge and you're taking very proactive steps. Okay, this is, whatever happens, you're recognizing, you're becoming body aware, you're initiating those conversations if need be with your partner, and then not waiting and not thinking that it's going to be a disaster. So that's going to be very, very important. So, surround yourself with the right expertise, surround yourself with great conversations with your healthcare professionals, with your gynecologist, with your endocrinologist, with your primary care physician, so that you're more equipped. And also remember, we have solutions now. So you don't have to suffer. We have solutions. And I tell that to myself, I don't have to suffer with, these symptoms. And we have the tools, we have the arsenal, we will be shielded. So get that care. Don't think that everything will be answered on the internet by searching for it, but actually, knocking the door or seeing that specific expert is really going to help. And don't add the fear and anxiety. I wouldn't.
Yeah,
The
absolutely.
second thing I would very, very much emphasize, which I couldn't do, was really focus on your strength training, on your exercise, on how you want to build your physical strength, because that really adds on to a lot of power as we enter into the next phase of our life.
Great. So here we're just going to do these rapid fire
Mhm.
questions. So nothing in depth, just kind of whatever comes to your mind. So what's one thing you're currently obsessed with in your practice?
Oh, time and getting fast results for my patients, not with weight, but with their mindset.
Hmm. And what's the favorite book or podcast that has changed how you think?
I could go back. The book that I remember reading first was Essentialism. I forget the name of the author, but it really taught me that if you're focused on one particular thing or one project, one goal, and putting all your energy into it, it is more fruitful. And your choices are all towards it, and the universe actually helps you towards that as well, rather than scattering your energy in different directions. So
Hmm.
essentialism, or how to be an essentialist, I think it's essentialism.
I like that. Yeah, actually, I read a book once. It was called um, "Do One Thing."
Uh-huh.
And it was about that, right? Like just focusing all your energy on one thing. So, what is the biggest lie we were told about being a woman?
Ah, that you're weak and you cannot get strong.
Yeah, it's interesting. Sex in midlife. What do you think? Overrated, underrated, or finally just right?
For the community, for everyone.
For everyone,
Yeah.
or for both? How about that? How about
It's
you talk about for
actually,
the
it's,
community?
yeah, it's, it is like perfect, but in the community or what I hear outside, it's underrated that, that this is how it's going to be when, especially when patients complain. But I feel like it's just getting right in that midlife. It's just getting perfect.
Hmm. And last question, one piece of advice you'd give your 30-year-old self.
Oh, get stronger. Like, I wish I could have engaged in strength training early on rather than after age 40.
But it's never too late. It's
It's
never too
never
late.
too late. No, I've gained 5 pounds now, like since last 6 months. So it's never too late.
Yeah. So for women listening to this and who feel lost, disconnected from their bodies, or unsure of where to get started, even if it's for cardiometabolic health, for libido, for sex, for menopause, where do you think they should start? What's your message for them?
Start with that awareness, start with learning, start with that curiosity, because you are the power. You are the power. There is no doubt about it. You could start with this podcast. You could start with resources that are being published in more recent couple of years, and then seek expertise. Don't try to find all the solutions. When there is support, when there's camaraderie, when you have a confidant, life gives you faster solutions, and it's easier to live life, more vibrantly rather than in misery.
Yeah. So for those people listening and watching, and they're like, wow, I just love Dr. Makhija. She is so awesome and she totally gets it. She gets me. How can they find you? Where can they get in touch with you?
Yes, thank you, Dr. Sadaf. So I reside in California, and I am on YouTube podcast. It's at Chhaya Makhija, MD. My podcast is Hormones and Hope. And if you wanted to see me as a patient, it's my website is unifiedendocrinecare.com. And anyone in state of California, I would love to be a part of your healthcare journey.
Awesome. Yes. And to all those, I mean, you take care of everyone, but for those people that are of specific South Asian background, it's always great to have a doctor that knows and gets it and understands their risk and their cardiometabolic profile and all of that stuff to help them live their life to their fullest. So, that's always important. And well, we are done here, and it's been real and really intimate. And of course, this is not meant to be any type of medical advice. So if you have any questions about your heart, your health, your libido, menopause, anything at all, make sure you go speak with your healthcare provider and get the help that you need. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.